So my job is to talk to you about Lutathera and the future. So I will tell you that I am neither a nuclear medicine doctor nor am I a medical oncologist. So you get what you pay for, okay? So this may be totally useless information. But hopefully it'll kind of give you a sense of the things. And it's actually, I really appreciate the brilliant Dr. Reedy was able to kind of warm things up for me by talking about what this PRRT is. But what I'm going to try to do is dive into a little more detail so you can hopefully have just like a deeper concept of what it means and how we think about it. Because as she said, and Dr. Gerstein said, and everyone has said today, basically these are all tools for helping take care of you. And it's true, I use the exact same words that she does. You milk each of the therapies for as long as possible. Because, you know, I can never guarantee how long you'll live, right? I cannot guarantee that. But we can do our very, very best for you to live better, so better quality of life, and then as much as we can, quantity of life. Okay, so this is what I'm going to talk about, your Lutathera in the future. But let me start real quick. I do want you guys to know that I have known this Wayman family for a very, very long time. And I've known these people since before since new generations of Waymans have come along. Yeah, you want to just advance it, Mikey? It doesn't work. Oh, it's down? Oh, my bad, okay. So, yeah, so I've known them for a very long time, and the work they do is very important. And so everyone knows that November 10th is Neuroendocrine Day, right? Everyone knows that, right? Because it's on the pin. Do you know why we celebrate November 10th as Neuroendocrine Day? Because it's Bob's birthday, that's right. Exactly. A lot of people don't know that, but I think it's really special. And so that's really great. And you can see the family I've been working with them for many years. This is a picture of me when I was much, much younger.
Just so you know, I don't generally get presents from everybody.
Oh, I know. It's like being, just like being born on Christmas. You don't get, you miss out on a whole batch of birthday gifts, right? Anyways, but the work they've done has been fantastic, and so I just want to make sure that we acknowledge them. Okay, so the first question you should always ask yourself, if you get diagnosed, or if you've even had it for a long time, is what should I do? And I do feel very, very strongly that you should go see a specialist. Like, I feel really strongly about that. So I am not a fancy academic doctor. I am a community doctor, right? I work in the community. I'm just a private practice doctor. There's nothing special about me. But I do think that it's very important to see someone who does this every single day, over and over and over again, because he or she will think about it very, very differently, right? He or she will have seen some like similar thing to yours, even if it's not perfect, and figured out how to fix it or what to do about it or something like that. Because Dr. Reedy is right. We do not have enormous amounts of data. Like breast cancer studies? You don't even qualify as a breast cancer study unless you have 25,000 people in the study, right? I mean, that's how these breast cancer studies are. So they know to the nth degree the detail of what it is to take care of a breast cancer patient. We don't have that, right? So there's still a lot of judgment that's involved with us. So I think seeing someone who sees this a lot is very important. And then, so after you do that, what is usually the first line of therapy? Anyone know? What is always the first line of therapy? Anyone know? That's right. That's good. Anyone know what the second line of therapy should always be? Yeah, you should have more surgery. That's right. Anyone know what the third line of therapy is? That's right. So I actually do know the sequence for taking care of neuroendocrine patients. I'm teasing, of course, but what I mean is that people sometimes underestimate the value and the power of surgery to help not only you feel better, for symptoms, but also to help control your disease, okay? And unfortunately, frequently, many of the people who say you can't have surgery are the people who don't do surgery, all right? So just think about that. If you asked your carpenter what kind of electricity you should put inside your house, you probably would not do too well, right? Or if you asked me what color to paint your house, I would say some shade of gray, right? And so you don't want to do that. You want to find someone who does this. So you want to make sure you see the right person. And it's true, you might get 10 different opinions, right? But at least you feel like you did your homework, you heard what everyone had to say, you can kind of evaluate what they had to say, and then you can go with the person that you trust the most, right? Because a lot of it is just, I know it sounds crazy, but a lot it's practical and common sense. And so your input into your treatment plan is incredibly important. Please, please, please do not underestimate how important your thoughts and feelings and symptoms are, okay? All right, so the goal of today's presentation is to talk a little bit about Lutathera, okay? And again, I'm not a nuclear medicine doctor, but I've been doing this for a very long time, so I do understand this medication quite well, I think. They did do a big, large clinical trial, so I'll tell you a little bit about that. We'll talk about some of the toxicity, right, because that's super important. And then I'll try to give you some nitty-gritty information so you can kind of understand, like, what does it actually mean to go through the therapy. I can tell you how we do it at our place, and then hopefully I'll give you a sense of what is happening in the future. Okay, so what is Lutathera? So the much bolder, bigger question, since there are no nuclear medicine doctors, is what is nuclear medicine? It's really hard to understand. Nuclear medicine is actually, it has become more robust recently. We used to call it unclear medicine because that's kind of how they practiced. They just made stuff up all the time. I thought it was the greatest field because you could just say something and no one could tell you if it was true or not. But they've changed it now, and it's really become very, very precise. And the tools we have changed a lot, especially, you know, with our imaging. About, what, 6 or 7 years ago, there was the wide release of this imaging agent called gallium dotatate. You may have heard of that before. It completely changed the way that I could see the disease. And so that was wonderful for the way we took care of patients. But basically, what I say, it's like giving liquid radiation. Okay? So just as Dr. Reedy said, you can shine radiation, and you can zap something, or you can inject the radiation. So it's liquid radiation. Now, there are a lot of letters that go into understanding this whole concept of nuclear medicine. So you may have heard of SRS, which is somatostatin receptor scintigraphy. That was the old Octria scan. Terrible, absolutely terrible. And then they developed this camera called the single photon emission computed tomography, and the pictures were miserable. I mean, I really felt very uncomfortable taking care of patients with that kind of information. But then we were able to bring this PET technology into neuroendocrine. So that's the gallium dotatate or the copper dotatate. We sometimes call it net spot or detect net. And that really improved things. But not only could we see based on it, now we could actually treat on the base of it. So, okay, so what does all that mean? So this is kind of what it looks like. Oh, sorry. So this is a new concept, kind of a new concept that we call theranostics, where the therapy is very, very tightly hooked to the diagnostic, right? So you need to have the two of them together in order to make it happen. I mean, I think there was, for some time, very much we were hoping that there would be more of this kind of stuff in oncology, and I think it's slowly evolving, but for neuroendocrine it works quite well. So just to give you a little pictograph, you can see here, this is the cell, all right? And then here are these receptors. So these are the proteins. Here's the lock, here's the key, and then here's the light bulb behind it, okay? So remember, when you're taking pictures with this gallium or copper dotatate PET CT, what you're doing is you're not taking pictures of the tumor. You're taking pictures of these proteins. That's what you're really taking pictures of. And unfortunately, there are some neuroendocrine tumors that do not express the protein, the receptor. So unfortunately, those cannot be imaged and usually cannot be treated T therapy. But if you want to, in addition to putting a light bulb, you can now put a nuclear bomb on the back of it. And that's how it works. And so it travels through your bloodstream, right? The tumors bind here, the receptor drug binds here, and it goes into the tumor. So the isotopes that we use, the radioactive isotopes that we use, are classically from here, right? So everyone remembers their physics, right? Right, and chemistry, everyone, right? So the problem is, this is in the, you got to move this, Mikey, can you move this one? Can you move it out of the way? Oh, perfect, okay. So does anyone know what this stuff is down here? That's right. No one knows what that stuff is down there. That's exactly right. So one of the isotopes we used was called yttrium. Okay, it was a very powerful radioactive isotope, and it had its benefits. But now the one that we use more routinely is this one down in the corner. It's called lutetium, right? And it has really fantastic features that allow us to use it for what we do. But I don't know if you know this, but it's been misspelled the whole time. That's really how it's spelled. Thank you. Too subtle? Too subtle. I know, that's right, Bob, exactly, too subtle. Okay, so everyone knows, lutetium-177 degrades into hafnium-177 with a half-life of 6.647 days. And if anyone wanted to know, the maximum radiation is 0.496 milli-electron volts. Everyone got that? That's very important for you to know, right? Super important for you to know. That's not important for you to know at all, right? This is what you need to know. Okay, these are pictures. I'm very good with pictures. Here's the receptor. Here's the cell. Here comes the guided missile with a nuclear bomb on the back of it. Your tumor cells eat the radiation, and you get radiation from the inside out. That's what happens. But it's not just to any one tumor that you can shine the light at. All of your tumors eat the radiation and get the radiation from the inside out. So it can look something like this. So basically, all those little funky atoms are inside there, and they give off radiation continuously inside of your tumors for weeks and weeks and weeks. And that's why the PRRT has such a powerful effect. It means so much. And not only does it go to any one tumor here, but it goes to every single black spot inside that gallium scan. Okay? Makes sense? I spent too much time making this PowerPoint. So just for an example, so this is a very extreme example. This doesn't happen to everyone. But very, very early on, a friend of mine was working with this molecule, and she had a patient. He had metastatic insulinoma, which is a very deadly disease. And she gave him the Lutathera, and all of his tumors disappeared. So we do see that every now and then. It is uncommon and relatively rare, but it does happen. So it can be quite magical in some cases. Okay, this is how it comes. It's not sexy. It is not sexy, right? It's like this vial in a lead pig that they hook up into your vein. It is, I mean, as much as we talk about it, this is all it is. This thing is like 2 pounds, this lead bottle here, okay? Oh, sorry. And the indication, just so you know, as Dr. Reedy has said, the indication is for the treatment of somatostatin receptor positive, right? So your scan has to be positive. Gastroenteropancreatic, so digestive neuroendocrine tumors, including foregut, midgut, hindgut neuroendocrine tumors in adults, okay? So unfortunately, that does not include kind of lung. And there are some insurance companies that will deny you if you have lung. Here's the molecule. Basically, it's a guided missile with a cage and a tiny nuclear bomb on the back. Okay? That's how it works. Just as she showed you, it infuses into your veins. It's nothing magical. It goes inside, your tumors eat them up, the radiation sits on the inside, and it beats on the tumor from the inside out. But you must have a positive scan. Okay, that's the whole thing. And I only show this because I think it's important for you to see the evolution of our technology. So in the past, we used to do this thing called this Octria scan, and you can see it. You know, maybe if you squint your eyes, you can see a few more tumors, right? You see the one that's right there in the middle. But then if you get a DOTATATE scan, you can see how clear it is. All right, and it's quite dramatic. And therefore, when you give the Lutathera, it treats all this. So this was a patient of mine, actually, and he had these scans just a few months apart, and they were debating, a very well-known group was debating if they should do more surgery for this patient. And when we did his DOTATATE scan, we were like, you don't need more surgery, you need more PRRT. So we sent him to Europe at the time to get his treatments done. Okay, so here's their phase 3 clinical trial. It's very classical, very similar to what Dr. Reedy had described to you, but basically they took the Lutathera, they gave patients who were progressing, and they specifically asked only in patients who had small bowel neuroendocrine tumors. Okay, so classically the small bowel carcinoid. And they compared it to patients who were getting double dose sandostatin. Okay, so sandostatin octreotide, LAR, is not approved at 60 milligrams. Okay, it is not. FDA said you got to do something. You can't just leave these people who are progressing and give them nothing. So they used double dose octreotide compared to their Lutathera. And what they wanted to see was how long could it hold the disease quiet and stable, okay, essentially. They had patients who had metastatic disease, and of course anyone who was too sick to receive it or had some other weird thing were excluded. But the issue was that it was mostly, almost essentially for small bowel neuroendocrine tumors. And you can see here the sites where they came from. But they had liver mets, they had bone mets, so it's very classic stuff. And then they also looked at the different grading of the uptake of the tumors. If you had very, very bright uptake, as Dr. Reedy said, usually they fare a little bit better. So they were looking at that as well. And what they found was quite striking. So if you had metastatic small intestinal neuroendocrine tumor that was progressing, if you got double dose sandostatin, you just kind of punked along, right? People just kept dropping off the curve because it's not a super powerful medicine and it doesn't work that great, okay? But if they got the Lutathera, you can see they did very well and fewer people fell off at the same rate. So you can see this difference here is what we're trying to accomplish and trying to do for people. And you can kind of drive a Mack truck through this, right? There are very few clinical trials, and there are very few chemotherapeutic agents. I mean, there are like billion-dollar chemotherapeutic agents with much worse results than this. So this is this was very encouraging and obviously gave us the new medication. And it was not ineffective at shrinking some of the disease. You could actually shrink some of it a little bit, but I would not call it super powerful. Only about 13% actually had some reduction in their disease. But so in general, it just kind of holds the disease quiet. But as all of us have seen, that patients who get this treatment, they live longer. So if you stay off of the Lutathera, you do fall off even with death, right? So people do die. And then here you can see if you stayed on the Lutathera, or you got the Lutathera, you had a slightly better chance of living. So that is really the end-all be-all as far as I'm concerned. Okay, it is not perfect, right? There are no treatments that have no side effects, otherwise they probably don't do anything. The major side effect we worry about has to do with your bone marrow, okay? So the bone marrow, just as with some of the chemotherapeutic agents, this is radiation, right? It's not fake. And so when the radiation kind of flakes off and goes into your bone marrow, it can reduce your platelet count, it can reduce your red blood cell count, it can reduce your white blood cell count. So all of those are possibilities. There is also some nausea and vomiting, which we don't have so much anymore. It's a slight difference. Some mild changes in labs, very, very mild changes in sugars and things like that. But generally it has to do with the bone marrow. So I'll tell you more about it, but basically people have a problem with fatigue for a week or two afterwards, and then it's the bone marrow we watch for so carefully. And in general, actually, the kidneys, which were a huge concern of ours, actually weren't that badly affected. So in fact, there's some doctors, we have a good friend of ours named Dr. Krenning. He doesn't even think it's toxic to the kidneys anymore. That's what he says. Now, one of the things we do watch out for, which can be quite dangerous, are these chronic toxicities. So you can see less than 10% have this condition called myelodysplastic syndrome, in which your counts are permanently dropped down. And in very, very, very rare cases, I know of a couple of cases, you can even develop leukemia. The only problem is I cannot tell you who is going to get that until you get the treatment. That's the So here you can see this is all real. They recorded it all, but in general, it's actually a very well tolerated treatment. The only problem is you can only give it so many times. Right? That's a problem. So you can see here, this MDS, acute leukemia, very, very unusual, but happens. Renal failure, very unusual. Low blood pressure, cardiac failure, heart attack, and neuroendocrine crisis. I've actually never seen any almost of these. I've seen this MDS a little bit, but I've really never seen any of the other ones. And I don't know if it's just the way that we take care of them or what the deal is, but it's very rare. Okay, So you can see here, this is the NCCN Comprehensive Cancer Network recommendation, and you can see Lutathera is right here. So luckily, it is well covered by insurance. Okay, so let me tell you some nitty-gritties of it. So the way I practice is if you have a gallium or a copper dotatate scan, you really need to have receptor there. So that means kind of how bright it is. And the SUV, the standardized uptake value, is a quantitation, so a number that tells you how bright your tumors are, how much receptor you have. And so the more, the better, essentially. Greater than 10 is kind of the cutoff, but I'd love to see 20, 40, 60, 80, 100. You know, those would be great scores to have. I would always say it would be good to have another pair of eyes look at the case, because sometimes there are people who get PRRT inappropriately. And the problem is you get 4, it becomes more difficult to give more doses afterwards. Because PRRT does not fix this, okay? This is, as you can see, an intestine that's tied up into a knot by a tumor right in the middle, right? It does not make the tumors really go away. So you're still going to vomit, and you're still going to feel sick, right? Or as I like to tell my medical oncology friends, the other thing you can do is if you really, really want a complete response, you can go to chemo, and maybe you can have a complete response after 3 or 4 months, or you can go to surgery, and maybe you can have a complete response in 3 or 4 hours. That's what I like to say. That's a complete response there. So I tell people all the time, if you see on your scan report an innumerable number of tumors, radiologists can only count to 10. So anything beyond 10 is sometimes considered innumerable. So it does pay to have someone take a look at your scans. Maybe there are other options available to you, that's all. All right, but back to be serious for a second here. So always a second pair of eyes. Now, it is best for kind of the low grade, well differentiated, slowly growing cancers, okay? It's not a super powerful therapy. It's not, okay? But it is effective in keeping things quiet for a relatively quiet disease. And of course, your bone and your kidneys must be okay, because they are toxic to both those organs. Although the kidneys are very forgiving now. Okay, so you have to also, as an insurance thing, you have to fail the somatostatin analog. You have to get the shot. They will ask you, I'm not paying for this until they fail the shot. Because the shot, while not cheap, is certainly probably, I don't know, less expensive per year compared to the Lutathera, okay? So you gotta get through that first. We usually like to wait about 4 weeks after your last shot. So that means right before the next cycle, because that lets the hormone kind of wash out of you before getting the Lutathera. So you have as many receptors available as possible. If you're symptomatic, you certainly can use the baby shots, so the little rescue shots they use 3 or 4 times a day. That you can certainly use. But remember, for us, we have to prepare for you. So it does take 2 weeks for us to order it as well, too. So you got to give us a little heads up. So you can't have it the next day. We do give you this renoprotective amino acid combination, which works very well and is less toxic than when we first did it in the clinical trial. We give it as 4 cycles every 8 weeks, right? So it's not quite like chemo where you get every week or 2 or 3 through a port or a pump or something like that. So this is just given through an IV. But we do have to check your labs pretty frequently because of the bone marrow problems. You certainly can keep giving the shot in between treatments, and it's almost exclusively excreted in the urine. Okay, so that's what happens. And it goes away very, very fast. So basically your kidneys just pee out most of all that medicine, and whatever's left over in your tumors is what's left over to treat the tumors. So this is kind of a schematic of it. So here you are here. Here's treatment number 1, treatment number 2, 3, 4, it's 200 millicuries or 7.4 gigabecquerels, given roughly every 2 months. The only thing is we like to keep you on schedule. Now, if you're sick or your labs are off and you need to have a little more time, it's certainly adjustable. But because it's such an expensive therapy and we have to order it, we want to keep you on schedule. It's very, very, very expensive. Okay, this is how we do it in my place. Basically, we decide you're suitable, we check all your labs, we order the dose, and then we actually place in what's called a PICC line. It's a double lumen, like an IV, a special IV that goes into your arm. And the reason we do it is because it makes it much easier for the nurse the next day to hook you up. Because one thing you don't want is for them to be tiddling around with an IV and then it's not working and they inject radiation, it spills all over the place, right? So we're very thoughtful about that. And they come in the morning, we give the drug, we give some amino acids, they get to urinate, and then we remove the line and they go home. It is not anything fancy. It's tedious, it is good, it's very expensive, but it's nothing fancy. But it was such a big deal that we really, oh, and these are the precautions, okay? And a lot of these things are precautions. Like I told you, it just, it comes out of your urine, so you have to watch out for that. But basically, we give some precautions about spacing from people, maybe not being around pregnant women all the time, maybe not being, sleeping with a loved one or spouse or something like that, just so you can have a little bit of space for a few days. And those are just precautions, I would have no qualms giving a hug to a person who just got, PRRT just for a few seconds would be okay. So this is what it kind of looks like, okay, just so you can see it. So here's an infusion of the PRRT going in, and you can see here's the Geiger counter. It's not fake. See it? That is real radiation going from this little line straight into his IV right there. And here it is, right? There are a couple different ways to do it, but essentially you can give it through this little thing, and it's nice because it's lead lined, right? So it protects the caregiver, not the caregivers, but the healthcare professionals. And you can see this is a Geiger counter walking up. There's essentially no radiation from a distance, okay? Because it's the farther you get, the less radiation you get. You must get all the way up into the patient's, personal space, essentially, to get the teeniest, tiniest little bit of signal. Right. So it is not a very dangerous kind of exposure kind of therapy. Now, I'm not going to lie to you. There were some cases in which the patient died, and the patient was cremated, and they found radiation in the cremation machine, right? So that was pretty controversial. Luckily, it was safe. Everything was okay. But it's very safe for the surrounding loved ones. And you can see here, when you get it, you look pretty normal. I mean, you just kind of sit there. It's more boring more than anything else. But it was such a big deal that we actually knocked down the first floor of my office building and built a new theranostic suite. Yeah, we really thought it was a big deal. Maybe not so much for neuroendocrine, but that prostate stuff that Dr. Reedy mentioned, that's a big deal. There are a lot of patients who need that. So we tore down the whole first floor of the building, and we built a theranostic suite. So now we have multiple chairs. We have this little room that's lead lined that the nurses can sit in safely. But the most important thing for the room, bathrooms, multiple bathrooms. So I tell people all the time, if it's good enough for the Colorado State Penitentiary, it is good enough for me, right? There you go, a steel metal toilet that you don't have to wash over and over and over again for protocol. But it's a big deal. And so I really think theranostics is the future. Not only, well, hopefully for us, of course, but also for many other cancers. Hopefully for prostate, maybe for lung, maybe for brain. Maybe you throw in those oncolytic viruses and we're really getting someplace. So what does the future really hold? Basically, in the PRRT world, there are three things you can do. You can either get yourself a new guided missile, right, which is a new peptide. You can change the nuclear bomb you put on the back, which is a new isotope. Or, as was kind of touched on previously, you can combine different things. So either new therapies or new different types of treatments, and even put them together. So sequencing is important, but maybe they can go together as well and help each other. So here are some of the new peptides, right? So these new guided missiles. You can see here there's a one that's really very, very close. It's lutetium-177 edotrietide. Okay, sometimes we have called it DOTATATE, if you've heard of that before. And it is a very similar kind of thing. It's a new it would be a new product, so kind of competing with Lutathera, but a same principle. But it's almost finished. They have this COMPOSE trial and this COMPETE trial looking at the comparison between this Lutathera and everolimus, right? And that's actually really interesting for the oncologists because they can actually look at what their therapy does head-to-head with this new type of radiotherapy. There is the other agent that Dr. Reedy talked about too. It's called 177 lutetium saterietide. She called it JR11. And they worked on it, seemed to have some issues, so we'll find out. I think some other groups around the world might be working on it, but it's not being currently worked on here in the United States. And one that's actually very interesting, actually, that Dr. Reedy has as well too, is lutetium-177 DOTATATE. Okay, so this is a molecule that has it's really interesting. It has a small dye on the back of it. It's called Evans blue, and it changes the pharmacokinetics of it. So maybe it works a little bit better, a little bit longer. Maybe she can tell us a little bit about it someday. But these are some new peptides which will help out. Now, what's most exciting, actually, as she had mentioned also, is this alpha emitter. Okay, so this alpha emitter is a big deal because it's a totally different kind of physics, all right? So dig deep back into high school physics, all right, for me. And remember, there's the gamma emission, so a gamma particle, a beta emission, which is an electron, and an alpha emission, which is a small nucleus. It's 2 protons and 2 neutrons, all right? So the way I kind of describe it is, if you have a gamma emission, you're essentially kind of shining light out. That's all it is. It's very, very weak. It's mostly for sensory purposes, This beta emission is a little bit like BBs or marbles, right? So you can whack them around, but most people don't die of BBs and marbles, right? However, the alpha emission is a little bit like a bowling ball. Okay, so if I hurl a bowling ball at you, there's a fair chance I can knock you over and give you a concussion, right? So that's kind of how you can think of these things. And so, by the way, if you really thought that you were going to turn this from gamma radiation, that doesn't happen, all right? So science fiction and medicine don't always cross. But almost science fiction and science can cross, because this particle can go and damage 2 strands of DNA. And when you go and you bust up the DNA, you may have a good chance, a real fighting chance at killing the cancer. And so here's an example. This is a slide from our dear friend Dr. Delbasan in Houston, Texas. And this is a patient of ours. He had lung neuroendocrine. It was in like chronic pain, really having problems. I didn't have many more options for him. So we sent him down to Houston. He got treated, and you can see here after 2 treatments, his tumors have shrunk. After 4 treatments, his tumors have shrunk. And after 11 months, his tumors are gone. And I saw him a couple months ago, and I still can't find any cancer in him. So it's really quite astounding. It's quite astounding. Now, this is an exceptional case. I will say that, because I've also seen patients from the trial who have not done nearly as well. All right? But this potential is very, very exciting. And then you can see here, sorry, I should have muted this, I apologize. And then what you can see here there are 2 agents. The one I just showed you was the lead-212, and another one that's called actinium-225. And at least from Dr. Delpasan, he's seen no significant hematological, so bone marrow, kidney, or liver toxicity beyond what we saw with our Lutathera. Actually, in his hands, now it's a very small study, in his hands, he saw 75% of the people have some shrinkage. And at least in 11 of those 12 patients, they didn't see any progression. So there's good promise. And so this trial is being opened a little bit wider. Now, this is a little bit different because this particular trial is only available to people who have never, ever seen PRRT before, right? So it's a naive treatment. Whereas this one from another company is one in which you can actually follow traditional PRRT. So that's an option. And as far as the combinations go, you do have lots of things that people are trying. They're certainly trying some immunotherapy, some CAP, some telotrestat, so the drug that we know is Zermelo, even different kinds of radiation together. They're trying other types of mechanisms like a PARP inhibitor, and even I found one with Cabo and PRRT. So people are trying these different mechanisms. People are infusing it differently, people are timing it differently, people are dosing it differently. So it's really exciting to see the different variations that people are testing. So hopefully between those types of futuristic things, we can really not only go to the next generation of PRRT, but optimize how we give it. So it is very important. I think you've kind of gotten the picture today that every person is very different, right? Every symptom is different, every presentation is different, every scan is different, every location is different. So the whole zebra thing is very apt. So if you guys ever get tired of zebras, do not ever come to my office, because it looks like a zebra had diarrhea and vomit in my office at the same time. So there's so many zebras. But I do think it's very appropriate because everyone's different. Everyone's different. everyone's different. And as Marianne had mentioned, we do have a foundation which is dedicated to you. It's called the Healing Net Foundation. We have a lot of information. We've produced a couple of different publications you can take a look at, which will help you hopefully understand your disease a little bit better. We have a new executive director named Tracy. She's really terrific. And so you can see here, there are a lot of people who are thinking about you very, very hard. And so hopefully with the work that's being done here, right in front of us, and the work that's being done behind the scenes in clinical trials and in different ways, we'll find a way to really treat you all better and make your quality and quantity of life much better. Okay, that's all I have.
Thank you, Dr. Liu.